posterior to the tongue and uvula, and as well as posterior to the hard and soft palate, is the pharynx. The pharynx acts as a catcher's mitt for the things that we swallow. You have a nasal pharynx or a nasopharynx. You have an oral pharynx, and you have a laryngeal pharynx. Nasal pharynx is associated with the back of the nose, where the nose connects to the back of the throat. The oral pharynx is associated with the oral cavity, and the laryngeal pharynx is, of course, associated with the larynx. Again, these muscles act as a catcher's mitt for everything that you swallow, and they do so by incorporating three U-shaped muscles known as constrictors. You have three constrictors. You have a superior constrictor that is associated with both the buccinator and the mandible. You have a middle constrictor, which is associated with the hyoid. And you have an inferior constrictor that is associated with the thyroid cartilage. The inferior constrictor will eventually close off to form the esophagus. It is these three muscles that receive food and direct it towards the esophagus, if you will. These muscles are all innervated by the vagus nerve. Next is the eye. The most anterior structure in the eye is the cornea. The cornea is a clear, multi-layer connective tissue. As you know, it's highly innervated. Get an eyelash in your eye, it feels like a huge, gigantic rock. It's very sensitive. It also protects the lens and the other structures posterior. Looking through the cornea, we see the iris. The iris is what gives our eyes color. The iris is made up of smooth muscle. As the iris contracts or relaxes, it either enlarges or constricts what's known as the pupil. Our pupil is black because as you look through the cornea and through the pupil, you are looking towards the back of the eye. Since the iris is made up of smooth muscle, it can both contract and enlarge to change the amount of light that gets into the eye and gets to the optic nerve. In situations that are bright, the iris should close down. In situations of dark, the iris should open to allow more light and more sensory information to get to the optic nerve. Things like alcohol or drugs may change or slow the responsiveness of the iris to change the size of the pupil. You might think that this may not be applicable to you, but you may have patients that cannot afford pain medication that come in intoxicated. And you may see that their pupils are extraordinarily large, or they are not adapting to changes in light as they go through the clinic. Drugs can do the same thing. Now, as the light comes through the pupil, it is directed at the optic nerve. Well, brain tumors that affect the optic nerve can also affect the iris's ability to change the size of the pupil. such that a tumor to the optic nerve on one side within the brain may make one pupil very, very large and another pupil very, very small. This is not normal. Your pupils should be the same size right to left. Looking through the pupil, the next posterior structure is the lens. The lens is an elastic, clear collagen that untethered would roll up into a ball. It is stretched out, if you will, because it is attached to the suspensory ligaments that suspends the lens posterior to the pupil. And the suspensory ligaments are attached to the ciliary bodies. It is these ciliary bodies that contract and relax in order to change the shape of the lens to focus on either something close or something far. So the ciliary bodies, through contraction and relaxation, change the focal length of the eye by changing the shape of the lens. People that have to wear glasses to either see near or see far, it's likely due to suspensory ligaments rupturing or suspensory ligaments becoming stretched out, so they are less able to accommodate for either near vision or far vision. Posterior to the lens, we have two vitreous bodies. These are basically two fluid-filled bags that help to maintain shape of the eye and, more importantly, maintain distance between the lens and the optic nerve. Any change in the vitreous body and change in focal length between the lens and the optic nerve can change your vision. As you know, severe dehydration can cause blurred vision. This is likely due to dehydration within the eye itself. Posterior to the vitreous body, we find the optic nerve and retinal artery. The retinal artery is blood supply to the eye, whereas the optic nerve is sensory from the eye. The optic nerve has two sensory receptors associated with it. These are rods and cones. Cones are receptors for color vision, and their greatest concentration within the eye is at a location known as the fovea centralis. Focusing light through the lens on the fovea centralis will result in the sharpest color vision possible. Along the periphery of the eye, or along the lateral parts of the eye, you have a higher concentration of rods. Rods are for black and white vision. So if you want to see something sharpest in black and white, focus away from it and catch it in your peripheral vision. The early explorers knew this as they focused on the horizon while using their peripheral vision to study the stars. Next is the sclera. The sclera is a fibrous container or coat for the eyeball. It serves two purposes. Like the vitreous body, it helps to maintain the shape of the eye. It also provides for attachments for the muscles, the 6 muscles that move the eyeball. Last but not least, this retinal artery is important. When you go to the doctor and they look through your pupil and they look to the back of your eye, they are looking for specific patterns that the retinal artery can adopt. Early hypertension and diabetes can be diagnosed by seeing specific retinal artery patterns in the posterior eye. There are in fact volumes of books dealing with differential diagnosis based upon retinal artery patterns. All right, there are 7 muscles pictured on this picture, the first of which is not involved in movement of the eye. It is actually a muscle of facial expression. Here is the levator palpebrae superioris. The levator palpebrae superioris raises the upper eyelid. If it gets weak or stretched out over time, it causes a condition called ptosis, where the upper eyelid actually droops over the eye. The most common treatment for ptosis is surgery. The other 6 muscles on this picture actually move the eyeball. The 6 muscles are innervated by 3 separate nerves. The rectus superior rectus helps us to look up. Inferior rectus helps us to look down. The medial rectus helps us to look medially or towards our nose. The lateral rectus helps us to look laterally or away from our nose or away from midline. You have 2 obliques. The superior oblique, which uses that trochlea in the superior part of that orbit as a pulley. The superior oblique depresses and laterally rotates the eye, while the inferior oblique, pictured here, elevates and laterally rotates the eye. Let's take a look at innervation of these eye muscles. The levator palpebrae superioris, which is again a muscle of facial expression, raises the upper eyelid superiorly or up, is innervated by the oculomotor nerve. The oculomotor nerve innervates the superior rectus, medial rectus, inferior rectus, innervating the superior oblique is the trochlear nerve, or cranial nerve 4. Remember, this superior oblique uses the trochlea as a pulley, and it is thus innervated by the trochlear nerve, or cranial nerve 4. The other muscle that is not oculomotor nerve is the lateral rectus. As you recall, the lateral rectus helps us look laterally, or another word would be to abduct the eye. It is innervated by the abducens nerve, or cranial nerve 6. So the lateral rectus is cranial nerve 6, abducens. The superior oblique is cranial nerve 4, or trochlear. All of the other muscles of the eye, the superior rectus, the medial rectus, inferior rectus, and inferior oblique are all cranial nerve 3, the oculomotor nerve. If you lose cranial nerve 3, you are said to be down and out, because the only functioning muscles will be the lateral rectus, which brings your eyes out or abducts your eyes, and down due to the action of the superior oblique, which depresses and laterally rotates the eye. Expect some lesion questions of either the nerves or weaknesses within the eye, asking you what cranial nerve may be involved. The last area to talk about is the ear. The ear has 3 distinct sections. The external ear, or outer ear, contains the auricle auricle, as you remember, basically means ear. The auricle is made up of skin and cartilage and is basically a catcher's mitt for sound waves. The sound waves caught by the auricle are then funneled through the external auditory meatus, which is a bone in the skull. So the external ear is made up of the auricle and the external auditory meatus. The sound waves then travel to the middle ear. In the middle ear, the sound waves are converted to mechanical energy. Sound waves from the external ear come through the eustachian or auditory tube and vibrate the tympanic membrane. The tympanic membrane and the bones of the middle ear, which are the malleus, incus, and stapes. The stapes, due to the vibration of the tympanic membrane, will vibrate in and out of the vestibule. So again, sound waves are converted into mechanical energy in the middle ear. It is past the tympanic membrane that the chorda tympani runs, which is the branch off of the facial nerve that provides taste to the anterior two-thirds of the tongue. You'll recall the last time you were in an airplane or maybe traveling somewhere where you were at elevation and your ears sort of filled up and your sound became muffled. Well, as the pressure within the middle ear goes up, the stapes, incus, and malleus are less capable of moving in that high pressure environment. That higher pressure within your ears that also accompanies head colds can also affect your chorda tympani, thus decreasing taste in the front of your tongue. So what do? We either wiggle our jaw or we exhale into a closed nose. And you know the nose is connected to the ears through the eustachian tube, and that those ears pop. So we equalize the pressure within the middle ear by blowing into a closed nose. The stapes will oscillate in and out of the vestibule, and the vestibule is the first part of the inner ear. The inner ear contains two different compartments. So we went from the outer ear being a receiver of sound waves. The sound waves were then converted into mechanical energy at the middle ear. Well, that mechanical energy is converted into fluid waves in the inner ear. The inner ear consists of the cochlea. The cochlea is where our receptors for hearing are located, as well as the semicircular canals. The semicircular canals are responsible for both position sense as well as balance. The inner ear is innervated by the vestibulocochlear ear, or eighth cranial nerve. And if you look at the semicircular canals, they create a bit of an 8 when viewed from this angle. So that 8 I see is for the eighth cranial nerve or vestibulocochlear nerve. So infections and issues with the middle ear will cause hearing problems only, while an infection or an issue with the inner ear can cause both hearing and problems with balance. You'll learn techniques to help with balance problems related to the inner ear in your neuromotor, neuromuscular courses. Now, as you'll recall, way back in the beginning of the term, along 7 weeks ago, I said you would not have to know the cranial nerves all at the same time, but we would in fact cover them as we covered the structures that they innervate. Well, for this exam, we covered quite a few of the cranial nerves. Cranial nerve 1 is the olfactory nerve. That is really the only nerve that we didn't cover. Associated with the eye are cranial nerves 2, 3, 4, and 6. Those are the optic, oculomotor, trochlear, and abducent or abducens nerves. Cranial nerve 5, the trigeminal, is sensation from the face, as well as motor to the muscles of mastication. Cranial nerve number 7, the facial nerve, is motor to the muscles of the face. The vestibulocochlear nerve, cranial nerve number 8, is the nerve from the inner ear that serves as both a nerve that facilitates hearing and balance. The glossopharyngeal nerve is a nerve that's associated with the tongue. That's cranial nerve 9. Vagus nerve, cranial nerve 10. Spinal accessory nerve goes to the trapezius as well as the sternocleidomastoid. And finally, the hypoglossal nerve is the major motor nerve to the tongue. Helping you to understand the functions of the cranial nerves is this chart. I believe this chart is also located in the nerve section towards the front of your lecture test. This has both the name of the nerve as well as the Roman numeral. The functions that you'll be tested on as far as the test are going to be those functions that we talked about as we covered those structures. Last but not least, remember, for the written exam, you will need to know the cranial nerve number, as I will not in most cases be putting the name of the cranial nerve on the exam. There are plenty of mnemonics on the internet, both clean and dirty, to help you learn the names of the nerves and associate with them with the Roman numerals. There are also mnemonics on the internet which help you to remember or recall whether those cranial nerves serve a sensory function, motor function, or both a sensory and motor function. This may also be helpful on the exam and will definitely be helpful as you tackle neuroscience next semester. That will be the end of the third part of the neck and head and will conclude the voiceover PowerPoints for this course.